Hi, everyone. I am your host, Aaron Fine, and I am the social media marketing coordinator for MS Focus. Before we start this wonderful webinar, I'd like to introduce this year's National MS Education and Awareness Month booklet slash toolkit. The theme for 2025 is The Whole Picture, Leading a Better Life with MS. We wrote this toolkit to provide you a holistic approach to tackling MS. If you're currently subscribed to our MS Focus magazine, please be on the lookout for your 2025 toolkit in the next few weeks. If not, please respond to your registration email for this webinar so we can add you to our mailing list. To make this toolkit in today's webinar possible, I would like to generously thank our wonderful sponsors, Sanofi, Genentech, Novartis, and EMD Serono. Thank you everyone for joining us today, and I hope you enjoy this webinar. Now, I am more than thrilled to introduce our speaker. Cherie is an MS certified registered nurse who is also the patient healthcare liaison for the Multiple Sclerosis Foundation. Cherie, we are so pleased to have you join us today to share information on this important topic. Take it away whenever you're ready. Thank you so much.
Thank you, Aaron. I appreciate the introduction. We've got some good programs in store for you this month. The sponsors that Aaron just mentioned are providing monies so that we can bring you a number of different educational themes. I'm going to start out today with neglected symptoms, or symptoms we tend not to always bring to our doctors. We're also going to have Dr. Ben Thrower next week talking about new medications and new treatments that are in the pipeline. Some are close to being ready to come out, and others are maybe five to 10 years down the road. We're going to be talking about mental health and nutrition and MS in the workplace and how to choose your MS disease modifying therapies. So we've got a full month for you with half a dozen webinars instead of our usual 3 to 4. And also, just want to remind all of you that we do have exercise videos on a regular basis every single week. And we also have art programs every single week that we live stream for you. So we do have a lot available for you. Today, what I wanted to talk about with neglected symptoms are things that we often don't take to our doctors. I have experienced trouble swallowing on occasion, and I just thought it was me being careless or me maybe giving my 2 cents worth on a conversation when I had food in my mouth. And one of the things that I discovered is that if I turn to look at somebody at the table while I'm chewing and I go to swallow, it often goes down the wrong way. So swallowing issues, if you do have them, I ended up finally letting my neurologist know after experiencing this for maybe a year and having an episode of pneumonia because I'd aspirated something. And he did a swallowing study, which is a really non-invasive, easy test. You just drink some liquid that is radiographic dye, and it's perfectly safe. And within 5 minutes, you've been imaged as you're swallowing, and they make a little video of that. And what they discovered was that there was a flap in the back of my throat that was not closing fully unless my head was straight up and maybe even tucked chin a little bit. But if I turned it to the side, it wasn't closing fully. So those sorts of things should be brought to your doctor if there's something like that going on. It's an easy diagnose, and a speech therapist is the individual, the healthcare professional that helps to deal with that. Last month on February 11th, Dr. Thrower did a talk on bladder health. He touched a little bit on bowel and sexual function, but those are things that, because they tend to be a little bit embarrassing, we may not bring up with our doctors. We may opt to take care of them on our own. Dr. Thrower did mention some things that are now being used, particularly in women who have a lot of leakage or incontinence, that traditionally were only used on men before. One of them is a drug with the brand name Flomax, and it's been used for decades for benign prostatic hypertrophy. So if a man's prostate is enlarged, it may kind of shut off or narrow the urethra, the tube coming from the bladder to the outside, and make it harder to void. And they're finding that with some women now getting that Flomax into them, that they're able to hold more urine for longer. The other thing is that Cialis or tadalafil, another drug that's used for erectile dysfunction in men, is seemingly helping women to increase the capacity of an overactive tiny bladder. One thing that he didn't mention that our friend Marie Namey, who used to work at the Cleveland Clinic and was kind of the bladder and bowel specialist that we all went to for help with symptoms of MS, bladder and bowel dysfunction. Marie used to show up at talks with balloons, and she would have a balloon with about a half pint or 500 cc's of liquid in. And she would show up with a balloon that had a cup, about a cup of liquid or 250 cc's of water in it. And she'd show up with one that had about 100 cc's in. So there were 3 different size balloons. And she'd say, this balloon with the half pint is what a bladder that refuses to empty, an underactive bladder where you're getting overloaded and may need to catheterize in order to empty your bladder. This is what it looks like. This is what it should look like. And this is what a hyperactive bladder looks like with only about 100 cc's before you void. And she said there's an easy way that I tell my patients that they can sort of guess how much they're voiding at any given time without putting something under them, catching it, and measuring it. Most women will void at about 15 cc's a second. So you can count the seconds of your stream. Most men void about 10 cc's per second. So if you're female, take the number of seconds that it's taken you to empty your bladder, multiply it by 15. If you're male, take the number of seconds it's taken you to empty your bladder and multiply that by 10. And you'll get approximately how much urine you have voided. If it's around 100, if it's even 150, you probably have an overactive bladder that is not emptying, that's emptying too frequently, and you may need some medication to help manage that, including possibly one of the ones I've just mentioned that has been previously used only in men. If you're a male, then you may need to see if prostate is enlarged and you need to address that issue. If you've got an underactive bladder or even an overactive bladder and you're not emptying fully, any urine that's left in that bladder has a tendency to just get, I like to call it stale. Urine that has set around, urine is sterile when you void, when it's voided out fully and immediately. But if it sits in the bladder over a period of time and you're only getting rid of part of it, it allows for bacteria to get into the urine and cause a urinary tract infection. It also, when you're not emptying your bladder, it allows the urine over time to back up the ureter into the kidney. So it pushes that stale urine up into the kidney and causes kidney infections, which are much more difficult to treat than bladder infections. And so that's something that's a real potential harm that comes out of you trying to manage it yourself and not seeing a doctor to find out about it. Um, Dr. Thrower's video is well worth the watch for anyone who's had any kind of bladder problems. The last time I checked, it still had not made it to our YouTube channel, but if you go to the Public Multiple Sclerosis Foundation Facebook page and scroll down to actually tick in Dr. Thrower to search, or scroll down until you find February 11th. That video is still there, archived, so you can still watch that video. Bowel health is another one that we're seeing a lot of people with MS tend to be constipated. Now, I know a lot of you are going to say, I'm never constipated. If anything, I'm just the opposite. I have a lot of liquid stool and I need to get to the bathroom in a hurry. That, my friends, is severe constipation. You've got a plug upstream and the river's working its way around it. So if you've got liquid stool all the time and it's really you need to be near a bathroom all the time, it's almost always because you are actually constipated and you've got a plug up there that needs to be addressed. I've heard for years that you need more fluid. You need to get some fiber into you. Fiber from food is preferable to taking a fiber supplement. But fiber from food means you've really got to commit to fruits and vegetables and grains to get that fiber. Things like processed foods are going to make your constipation worse. Even your standard, one of the worst things for constipation is your standard white sliced bread that you're buying at the grocery store. It's so full of processed ingredients that aren't even really food, that it does not have the fiber that you need to get things moving. So if you're able, get yourself used to eating multigrain breads. They're better than nothing. And if you like to make bread, homemade bread's even better. I love to add something like Bran Buds or all brand cereal when I'm making bread. That does help add some extra fiber. If you're making muffins, you can add that to them as well, and that will help. But I must warn you that if you're going to take fiber supplements, you really have to hydrate because those fiber supplements can really become like cement and often require medical intervention. I've seen patients when I was still working in the hospital setting. I've seen patients come in to the emergency department with hip pain, predominantly hip pain, or even low back pain or pelvic pain, not abdominal pain. And when we do a CAT scan, we find out that they've got a high impaction of stool. So it's really important to stay on top of that, and let your doctor know there are medications other than just laxatives which can help to maintain that for you and keep things open. So I would say if you're not going at least every 2 to 3 days at the outside in more than just a small way, you really need to address that issue so that things don't get to the point where you can't manage it. Sexual health is also often related to MS symptoms and may be able to be addressed with a pelvic floor therapist. Most therapy departments, actually 20 years ago, it was really hard, except at spinal cord injury centers, that to find somebody that was trained in pelvic floor therapy. Now we're seeing most therapy practices that are more than 2 or 3 therapists in a practice, any large practice or a practice around a medical center, or generally also in our MS centers. We do have pelvic floor therapists, and they can help with bowel and bladder problems. They can also help with sexual problems, the inability to climax, or the with men, premature ejaculation. Those sorts of things can be addressed by a pelvic floor therapist. So don't suffer in silence with those. Emotional health is one of the things that will be addressed by Dr. Pearl Werfel later this month. But if you are finding it hard to find joy in your life, if there's more gray than colors in your palette of emotions, you don't have to be sad, you don't have to be crying all the time, but if there's not things that are making you happy and joyful at the same time, it might be helpful to talk to somebody about that. We're not pushing medicines on people as much as we used to for these sorts of things, but sometimes just getting a handle on things that might give you joy, things that might get you out of your rut. I'm finding that people that are sitting on their screens all day long are often having a hard time maybe finding that spark, finding that joy. Pets help, kids help, hobbies help. Getting out and getting fresh air for a few minutes every day is also very, very helpful. And I realize that there are some people that are listening to my voice for whom that's difficult, because you may not be able to access the outside as easily. And so I'm throwing this out as something that will help a majority of people. But I do recommend that if things are kind of darker than you'd like to see them, do get some help. Cognition, brain fog, really common as we age, but also very, very common for people with MS. And I know that a lot of people, myself included, would just say, I got to deal with it. I really don't have the time to tend to this or to have it diagnosed. But if you're starting to notice that the last few weeks, or even maybe the last couple of months, you don't feel as smart as you used to, you're having trouble finding words, you're having trouble putting sentences together, you're having trouble remembering conversations or remembering something that you've read, that is the perfect window to get a neuropsychiatric evaluation, to have a baseline. This is pretty important so that as you age, as your MS improves or worsens, you've got a baseline to look at, and then you can add interventions as time goes on. There are a lot of things that you can do to sharpen your memory, and I'm not just talking about brain games. I'm talking about hobbies. I'm talking about studying a language. New language acquisition is one of the best ways to retrain some of those cognitive pathways. Reading a novel. Actually, there have been a couple of small studies done that I've seen recently that have said that people who actually hold a book and read a book absorb more of it and retain more of it than if they were reading it on a tablet. So I would say those sorts of things can help cognitively. The MS hug is something we've talked about a lot recently. MS hug is just a muscle spasm in your chest, generally in your chest. I've heard it said by doctors and nurses as well, that it's not impossible to have like a band around your arm or a band around your thigh, um, cause feel like it's just a one-sided thing. Can also be the MS hug, but it is spasticity. It's one of the forms of spasticity. Many of us with the MS hug, because it tends to band our chest or even our abdomen, and it's usually all the way around. It's not a halfway, unless MS affects only one side of your body. And then I actually believe I've seen some people that do have a true MS hug that's on only half of their body. So it could be from the chest around to mid back. And it almost makes you feel like you're having a heart attack. I remember one August, probably 12 or 14 years ago, I was having a lot of chest pain. I was having shortness of breath. It was even going up into the side of my neck. And so I thought I'd best get to the emergency room. And I was in the emergency room for about 8 hours that day. And they did all kinds of labs and an EKG. They did a cardiac echo. And all of that came back normal. And I realized, except for the IV that they had running, I really hadn't had anything to drink all day because they were kind of waiting to see if anything needed to be done procedurally. And so I asked them for a large glass of ice water. And of course, they bring you the little Dixie cups with water. So my husband went home because we're only a few blocks from the hospital and got tall, um, a tall beverage container full of ice water. And I just gulped that down. That was probably a 20-ounce container of ice water. And as I gulped down the very, very cold water, it started to relax and loosen. And then I asked them for ice packs, and I put ice packs around the tight areas of my chest, and it let things go. I think I've had the MS hug a couple of times during the winter, when I certainly didn't want to put an ice pack on, and a heating pad did seem to relieve it. So the hydration, particularly cooling from the inside as well as the outside with ice packs or a cooling vest, um, can be very, very helpful for the MS hug. And if you've seen a neurologist or a cardiologist on several occasions for chest pain and all of the tests have come back normal and you do have MS, it's very likely that you're having a muscle spasm around your rib cage. And so I would do whatever you do normally to get rid of the muscle spasms, whether it's massage, whether it's heat or cool. Your doctor, if it's really bad and it can't let go, might suggest a muscle relaxant for you. So things like tizanidine or baclofen may help, or they may give you something like Flexeril, which I know some people have used and it has helped. So the MS hug can be handled those ways. I would say if you've had the hug for more than 2 days and you've done these things and it hasn't let go, you do need to talk to your doctor. Please do not go to the emergency room on a regular basis to treat this, because what's going to happen is they're probably going to end up giving you steroids. And steroids are really not good to treat symptoms in the moment. They're not good to be taking on a regular basis, meaning several times a year, because symptoms have flared. We really need to get a handle on those symptoms with our neurologists and make sure that we're on a disease modifying therapy if we're having these symptomatic flares, so that that can be calmed down, minimize the intensity of the symptoms and also the frequency of the symptoms. Some of us do experience sensory loss. I know that with COVID, we started really focusing on the loss of taste and smell, but loss of taste and smell is possible as an MS symptom. It's not a common MS symptom, but it certainly is possible. Things like feeling that there's water dripping down your leg, those types of sensory symptoms, or spiders on the backs of your hands, um, are things that there are ways to treat them. I find that temperature changes can sometimes help. Um, just running your hands, if say you feel like something's crawling on the back of your hand and there's nothing there, running your hands under warm water, not necessarily hot water, can be helpful in diminishing that symptom. Um, Sometimes if you've got a patch of neuropathy or nerve pain, you can use something like a TENS machine, which is a little electrical stimulation through pads placed on the surface. If I've got a spot that's about, actually, it's the size of a pencil eraser on the lower outside of my left leg. And it's visible and you can feel it, but it's extremely tender. And when it flares, it about sends me through the roof. Oftentimes just putting on a compression sock, knee highs or something like that, or even a pair of pantyhose can flare it. If I'm outdoors walking, particularly on a cold day and the wind blows across it, it will flare it. And I do find that putting a pad with the TENS unit just below that area and one above that area, um, just for 10 or 15 minutes, it makes it calm right down. So you just kind of distract it. You give yourself something different to think about than that and let it kind of calm down. So there are a number of things that you can do for that. My neurologist also suggested at one point that I try lidocaine patches. They are over the counter. Um, I don't handle the injectable lidocaine because I'm allergic to the preservative in the injectable lidocaine, but I do tolerate the patch and it does help. Um, they're probably 14 or $15 a box for 5 large patches that you can cut into size for whatever place on your body. They've got a little self-adhesive, but you can just put a sock over them to hold them in place, or a piece of tape if that's necessary, if there's any area of friction where the patch is. And so those things might be very helpful for you. Um, I think at this point, I would like to open this to questions. If you have questions for me, please put them in the Q&A and not in the chat. We're going to leave the chat open for people that are on Facebook. And so the first question, hi, Karen. First question are, where are the lesions if you have bladder or bowel issues? Are they only in the spine? And if so, where? They're generally around T10, 11, the lower thoracic spine. That's not to say that it isn't possible to have some in the brain. But again, the best way to manage those symptoms would be to get on an effective disease modifying therapy. Before people um, actually start asking a lot of questions, I want to just mention to you that if you do want to ask me the question personally, there's a raise hand button in the reactions at the bottom center of your page if you're on Zoom, and we can ask you to unmute. Aaron, did you want to read the questions? I can close this if you want to.
Yeah, let me help out a little bit, make things a little bit more easy on you. I would be more than happy to help out.
Thanks so
So
much.
with that being said, in terms of somebody raising a hand, we have an individual. Her name is Suzanne, and I'm going to allow her to talk and ask Cherie a question.
Thank you. Suzanne, are you on mute?
I'm not anymore. Can you hear me?
I can. Thank
Okay,
you.
wonderful. Of course, with this MS, I've had it for 27 years now. Um, Now my bladder and bowel are just, oh, that's just taking a toll on me. So, as far as the voiding equation is concerned, I think you said something like, as long as you urinated, it's like 15 cc's per second. And then you said times what to make sure to see if you're urinating 100 cc's or more? Because I missed some of that.
Okay, women tend to have slightly larger urethras than men, so we void a little faster than
Okay.
men do.
Mm-hmm.
And so women tend to void 15 cc's a second. So you're going to count 1,000, 2, 1,000, 3, 1,000 with your stream.
Mm-hmm.
And however many seconds it took you to empty your bladder, you multiply that by 15. And that'll give you a rough estimate as to how much urine you voided out of your bladder. If it's below 150 cc's, you probably have a hyperactive bladder that may need medical attention. So that's something you want to take to your doctor. They're probably going to send you to a urologist. I do recommend, if there's one available in the area for women, that they see a urogynecologist. And that way they're going to get, if your bladder problems are related to gynecologic issues, a lot of times women that have had vaginal deliveries may have had some injury, and their it's going to make them void more frequently. It's probably also more likely that they'll have problems with incontinence. So a urogynecologist for women is recommended, not necessary. A urologist can handle the problems for both men and women. So I hope that answered your question, Suzanne.
It does. Thank you so much. I know that I do have 100 cc's just sitting in my bladder. So I do see a neurogyne. So they're kind of working with me as best they can. So, but thank
I,
you
I,
so
I will tell you, Suzanne, I was very hesitant when I was having problems to start with intermittent self-catheterization. Um, it was actually one of my patients that got me comfortable doing that. Um, I showed up at her house to teach her how to catheterize herself, and I got in there and she said, I have to admit the box of catheters arrived, and I opened and looked at them and I thought, okay, I know that there's three holes down there, and I know it's not this hole, and I know it's not that hole. Must be this one. And so she said, I popped the catheter in, and it was so easy, and I felt so much relief after
much.
my bladder was empty. And I know that when I started catheterizing, I was getting a good 500 cc's or half a pint out of my bladder at a time. But over time, with a proper disease modifying therapy, pelvic floor exercises with the help of a therapist, that all kind of evened out. So don't be afraid if they recommend this to try it.
They have, but thank you so much.
Okay.
Fantastic, Suzanne. Thank you so much for your question. All right. So before we move on, Cherie, I just wanted to provide you with a compliment from Doris, who says you are providing outstanding suggestions. So
Oh, thank you,
Doris says thank
Doris.
you, as well as everyone else here, and myself included. So we're going to move on to an individual. She or he has two questions. This individual says, I have recently developed eyelid flutter spasms in one eye and also feeling of a trembling in my foot when I stand and walk, which comes and goes and feels like the ground floor is trembling. Is this rare? I've had MS since the 1990s, but these two issues are quite recent. I've never had them before. Thank you.
Okay. Um, the twitches, the flutters,
Yeah.
can be related to MS. They can also be related to other things. So it's something that you need to take to your doctor and ask your doctor to look into this. There are medications in severe instances that can be given, and they generally come from the seizure arena. Um, I don't really like to start out with something like that. Again, I find that oftentimes touch, like an eyelid flutter, if I just hold my eyelid shut with light pressure, the flutter will let go. And I don't know if the flutters that I occasionally get in my eyelid are related to MS. I mean, I've had MS for this October will be 50 years since my first hospitalization. So I am I'm kind of a poster child for living long and living well with MS, and it wasn't always like that. Um, so I know that there are things that like that can be uncomfortable or irritating. But even with like a twitch, sometimes I'll get a twitch in my forearm, on the side of my forearm, and just putting light pressure over it and holding it calms the twitch down. So don't be afraid to touch the area that's fluttery or trembly. It can just, it's kind of like laying hands on yourself. You're loving on yourself, and it does seem to help.
Wonderful. Thank you for answering that two-pronged question. So the next individual, this is more about medication. Somebody would like to know, I'm currently on oxybutynin for urgency and frequency. I'm wondering if Gemtesa would work better. Oxybutynin has helped me, but not enough, and I'm looking at other options. Excuse me,
Patrick,
Mirabetrip
yeah,
is too
it's too
expensive, so it's not
expensive,
an
so it's
option.
not an option.
Not an option.
Dr. Thrower did address that in his February 11th webinar. So again, I would recommend you go to our public Facebook page. Maybe Bhavya, if you could put the web address of that public Facebook page in the chat so that people that want to watch Dr. Thrower's talk can find it, or maybe if you're even able to find the talk itself, if it has a distinct web address on that page, that might be helpful to put that into the chat. Certainly, if one of those medicines isn't doing the job, another trial on a medication might be helpful. And I guess, again, that medication that's too expensive, it is very expensive, and many people can't handle the copay. So yeah, it does make sense to try another class of drugs with that.
Okay, wonderful. That's a very good suggestion. This next individual would like to know, are there any suggestions for nighttime bladder leakage? My significant other has leakage issues if he sleeps all the way through the night.
Yeah, I would I would recommend that you stop any liquid intake at all after,
Mhm.
like, if you're going to bed at 10 o'clock at night, I would stop fluid by 6 o'clock or 7 o'clock in the evening. No other fluid. Avoid bladder irritants like alcohol or caffeine before bed. Um, so those sorts of things, at least not within 3 to 4 hours of bedtime. Void directly or void fully before bed, and um, you might even need to start setting an alarm for like 3 or 4 o'clock in the morning to get up and empty the bladder, and see if that doesn't help with the leakage during the night. For men, there is something that, at least when I was in training, we called them Texas catheters. Um, they they're very similar to a condom that has an outlet on the end of it that hooks to a tube that drains the urine into a bag if you have an accident during the night or if you're incontinent. And those could help to keep the bed dry.
Okay, I think that's really good advice. Now, Cherie, this is actually just a question for me because I'm very curious. Do you think, in your professional opinion, that these issues actually exacerbate once you get to a certain age, or is it kind of like correlating to your progression with MS?
Um, they could be both. I know that historically, take MS out of the picture altogether. Historically, people begin to have more urinary frequency, need to, not what we call nocturia, needing to get up during the night to
Mhm.
void over the age of 55 or 60. So if you're a person who's got MS and has that propensity to have more urinary frequency or urgency or leakage, and you're getting into that age range, you could be dealing with a double whammy, which is one of the reasons why you want to steer clear of those bladder irritants near bedtime. You want to make sure that your bladder's fully empty. You can think you fully voided, but I'd recommend that if you're going frequently, if you're going more often than about every 4 hours, you want to sit there for an extra minute or so and try again to make sure that that bladder's fully empty. You might get another half cup of urine out if you just relax. Sometimes deep breathing and then letting things go will help.
Interesting. I mean, I feel like that, connects to a lot of individuals, but, as a gentleman who's also getting to a certain age, I also feel like I have to, evacuate a little bit more, during the night. So I feel like that really helps in a lot of different ways for a lot of people. So thank you for that.
You're welcome.
So
Oh,
next
just a tip,
individual,
just a
yes.
tip for the men listening to this. You're probably going to get better emptying of your bladder if you sit on the toilet rather than standing to void.
Any specific reason? Just because of maybe the
Just
muscle
because it relaxes the
relaxation?
muscles.
Copy that.
You're
Okay.
not having to support them as you're standing. The pelvic floor muscles are activated. If you sit, they sort of relax because your body's supported.
That's a great tip. Thank you. The next, and this also kind of dovetails into what we are kind of talking about. Someone would like to know, is it common for muscle relaxants like tizanidine to make you urinate more often?
Not generally, no. If anything, unless muscle relaxants, tizanidine particularly, I find makes me very dry mouthed. So I tend to drink a little bit more. That may be happening, and you may not be tying the two together. So you're taking in a little bit more fluid because you're getting dry mouthed. If I take tizanidine before bed, I'll usually wake up 3 or 4 times during the night, like cotton mouthed, and drink a little bit just to kind of take care of the dryness of my mouth. And then after, maybe half an hour, I realize I wake up and I realize I've got to go to the bathroom, and I go to the bathroom and I come back and my mouth is dry, so I take a little bit more water. It could be that the extra water is perpetuating that.
Wow. Okay. I hope that answers your question. Sandra would like to know, I have large white areas in the upper part of my brain. My neuro says they're not enhanced, so it can't be MS lesions. I've had very poor balance for months, and that's why an MRI was ordered. I think that was more of a statement. But is there anything that you can kind of comment on, Cherie, or do you think that
Yeah.
just need a little bit more
MS
information?
lesions are in very specific parts of the brain and they look very distinctly different. There are about a dozen conditions that have white matter lesions in the brain. Generally, the top part of the brain is not where you see MS lesions. The frontal lobe is not where you see MS lesions. You see them around the ventricles, which are, if you're looking at an MRI with the brain top down, it's kind of the little butterfly that you see in the center of the oval. If you have lesions that are touching the wings of the butterfly, those are pretty classic MS lesions, but their MS lesions are not really sitting on the top of your head. They're supraventricular and periventricular, so they're right around the ventricles. MS lesions also tend to have if they're magnified, the radiologist can see that the center of the lesion has a blood vessel in it. And non-MS lesions don't have that. So there's a very specific. Now, the enhancement of a lesion is indicating that you have active disease. It doesn't mean if they're not enhanced, it doesn't mean you don't have MS if the lesions are in the right place and look the right way for an MS lesion. So I hope that answers your question.
Um, this individual would like to know, what are some over-the-counter medications for musculoskeletal pain in knees?
Um, You certainly can try something like an NSAID, things like ibuprofen or Aleve. I would try the ibuprofen at lower doses, 1 or 2 capsules every 8 hours. Now, I don't want you overdosing on that. There's also that same medicine, same essential medicine is available in a product called diclofenac cream, which you apply to the area of discomfort. Please don't use the diclofenac cream and the ibuprofen or Aleve at the same time because you're overdosing with that kind of medication. It can cause some GI bleeding. It can cause some nausea if you're getting too much of that medication. And don't take Aleve and then if the pain is bad, take some ibuprofen. Don't double up on those same classes of medication. Aleve is every 12 hours. Your diclofenac or ibuprofen is every 8 hours. So don't double on those medicines.
I think that's great advice. That could be extremely scary. Um, our next question actually comes from Facebook, Cherie. What can we do to alleviate the crap gap symptoms? And in parentheses, the time before infusion.
Okay, if you're on Ocrevus, that's where we started really hearing about the crap gap because when it first came out, it was very rigidly at every 6 months, and people at sometimes as early as 4.5 months or 5 months were beginning to feel that their MS symptoms were worsening, and they got better after they got their infusion. The company that makes Ocrevus now allows providers to move that infusion up to 5.5 months. So you can infuse 2 weeks early if need be. Patients that are not keeping that relief with that 5.5 months, some docs are going to switch them to Rituxan, which is essentially the same medication. It's made by the same company. The difference is that Rituxan has a mouse model of the monoclonal antibody versus the humanized model that Ocrevus and Briumvi have. It's the same drug. It's been on the market for nearly 3 decades now. It's used for a lot of different conditions, so we know that the dosing can change. So you may get a lower dose more frequently to keep you from hitting that crap gap. It's also less costly, so a lot of insurance companies will more likely use the Rituxan than Ocrevus if for some reason cost is an issue with that.
Okay. Before we go to the next question, Cherie, and we do have a few more before we need to wrap up, I was hoping you could explain as concise as possible for those who might not know, what is the crap gap?
All right, the crap gap is take a drug like Ocrevus, which is given every 6 months. By 4.5 or 5 months, you're feeling like you've been doing fine since your infusion, and all of a sudden your symptoms are starting to worsen. They worsen until you get your infusion when you start feeling better again. So it's that gap between infusions, between your last infusion and when the symptoms start seeming like they're getting worse before your next infusion. That's what we call the crap gap.
Interesting. Okay. Hopefully that was informative for those who did not know. So someone would like to know, are MS infusions usually covered on Part B Medicare in a hospital setting?
They are at least at 80%. That's why we recommend that everybody get a supplemental policy to pick up the other 20%. I was on infusions for my MS for 11 years, and 100% of them was covered with Medicare and the supplemental policy.
Okay. Someone would like to know, do people with MS, once they start taking muscle relaxants for excuse me,
Spasticity.
spasticity ever, I don't know why it's fooling me today, ever get to stop taking the pills? Can
Yes,
one take them as needed?
yes, yes, yes. Um, Baclofen, you kind of need to keep your blood levels up to a therapeutic level. So that's not something you just take as needed. The one that you take as needed would be tizanidine, or Xanaflex. Same drug, just different names for the same drug, and they can be taken as needed over time. I know that there have been times where I've taken them every day, and other times where I've been months or even a couple of years without them, and then just use them if I'm doing a lot of walking, if I'm traveling and the spasticity ramps up, I can take them before bed and um, just take them as needed.
Okay. Christine from Facebook asks, why does my daughter's neurologist say pain isn't associated with MS?
Because they don't know that pain is one of the number one. We used to say for years that pain was not from MS. There are two very distinct types of pain that come with MS, not for everybody. One of them is a musculoskeletal pain, oftentimes from a gait issue. So if you've got drop foot, for example, you're very likely to develop hip pain or low back pain because you're hiking that foot to keep from tripping on it. And that involves activating the hip joint. So you're kind of walking with your leg out, you're kicking it out in front of you, and that can cause pain. The neuropathy that I mentioned earlier is very definitely a pain that's related to MS. So neuropathy is also fairly common with diabetes. So if you're a type 2 diabetic and you've got pain in your hands or your feet, it may be related to poorly controlled diabetes.
Um, Someone would like to know, are they ever going to come out with another type of contrast dye for use inside MRIs?
We've actually got several different contrast dyes now. Gadolinium was the one that we started having a lot of problem with. It wasn't clearing the kidneys. We used to think that it was out of the system. We were always told that it was out of your system within 24 hours. We now know that you really need to hyper flush your system. So drink 2 to 3 times what you normally drink on the day of MRI to get that flushed out of your system, and also the next day. The more fluid that you drink, the quicker it's out of the system.
Yes.
If you're having all three MRIs, your brain, your cervical spine, and your thoracic spine, do not get them on separate days. I know it may not feel like you can stay in the machine all that time, but you do need to have the contrast for all of them, at least initially. You should not have to have the spinal films more than just at diagnosis unless there are new spinal symptoms that your doctor is seeing. So you don't need to get the neck or the back every year.
Okay. Someone would like to know, um, I feel like my MS has gotten worse, yet my lesions are basically the same. Is that weird? Is there anything that I should be concerned about? What are your thoughts, Cherie?
If your MRIs are staying the same and your symptoms are getting worse, it's something that we call PIRA, progression in the absence of a relapse. So that is a fairly common thing, which generally tells us that you have transitioned from relapsing MS into a secondary progressive form of MS, not primary progressive MS. You cannot go from relapsing remitting to primary progressive MS, only to secondary progressive MS, but that usually will tell us that you've transitioned. It may mean that you need to switch disease modifying therapies. Um, Usually we will do that prior to the age of 65 or 70 even if you're doing that. Some doctors are hesitant to do that, but I would get a second opinion if that's happening.
Okay. Karen is curious whether you can talk about whether hearing loss and tinnitus are MS symptoms.
They can be if everything else has been ruled out. you really need to see an audiologist if you're having this going on, because it might be that it has nothing to do with MS at all. It could be, very rarely people will have some brainstem lesions, and it's from the brainstem area that the cranial nerves come out, one of them being the auditory nerve, which can be involved with tinnitus or tinnitus, pronounced both ways. So, all right.
Okay.
But you do need to see an audiologist if that's going on.
Fair enough. Can you briefly explain to somebody what smoldering MS is?
Smoldering MS, again, is what I was just talking about with PIRA, progression in the absence of a relapse. So your symptoms are getting worse. Your MS is kind of smoldering. We're seeing with a higher image, the 3 Tesla MRIs, actual disease activity happening that isn't picked up on a 1.5 Tesla MRI. And that has been dubbed smoldering MS. So it does need to be treated.
Absolutely. Gina would like to say, um, if my lesions are inactive, is it possible to be feeling symptoms like fatigue, heat, intolerance, muscle spasms, etc.? I've encountered many medical professionals that insist that if I'm in remission, period, then whatever I'm feeling is not MS related.
That is so wrong. That is so absolutely wrong. If they're telling you that, they're not an MS specialist, and you need to get yourself to an MS specialist and not a general neurologist. They just treat so many things that are neurologically based that are not MS, and there's so many advances in the field of MS treatment that they can't keep on top of all of it. Dr. Boster likes to say, if you've got 3 kids and you decide to go on birth control, you still got 3 kids. If you've got MS and you've got fatigue and you've got spasticity, you still got them, even if you go on to a medication. I know that they get better for me when I'm well managed on medication. They don't go away. They never go away. They're worse when I get overtired. They're worse when I get overheated. But you've still got MS. And the MS is going to make itself known if you're overtired, if you're stressed, if you're fatigued, or if you're overheated. So yes, that's a very, they're telling you something that's just plain not true.
That's great advice. Thank you, Cherie. Christina would like to know, I've been using the same medication for over 15 years. Does a body start to become immune to the medication after, a considerable amount of time?
Um, if if it's working, I would say, if you're getting worse, then that's the time to have the conversation about changing medications. If your MRI is stable and your symptoms are not getting worse, you should be fine staying on that medication.
Okay. First, we have a nice little comment from Karen who just says she's very grateful for you and wants to thank you for everything that you've done today and everything you've done previous. So we're going to keep moving. We have a few more questions. We'll try to get a few more in before we have to end today's program. Someone would like to know, Cherie, your personal opinion on Ocrevus versus Vumerity.
Oh, they're not even it's like comparing apples to oranges or horses to zebras. They may look similar. They do not work similarly. Vumerity is a mid-efficacy drug that's taken orally. Ocrevus is in our group of most high efficacy drugs that we have. So if you have a very active form of MS, if you've got changes on your MRI, my recommendation would be to go with something that's more high efficacy, like Ocrevus. If you're stable and you're just needing to switch to a different medication, you can try Vumerity, and after a few months to a year, if there are changes on your MRI, you might want to bump up to Ocrevus.
Okay. Gus from Facebook asks, neurologists say having a long gap between relapses is better for the long-term outcome. What timeline gap is considered a long gap?
We want to see you stay relapse free for at least 2 to 3 years. Um, Early on, not early on, but before I actually was able to get onto any medication for my own MS, I was having easily 3 and 4 relapses every year until it got to the point where they were piling on top of each other. And at the time that I got onto medications, we had very, very few things to choose from. So it really took a number of different things to get those relapses under control. But if you're having a relapse or two a year, you definitely need to be on a more high efficacy medication.
Okay, wonderful. Cherie, do you have time for one more question?
I can stay for a few minutes if need be.
Oh, wonderful. Okay, so we'll try to breeze through a couple more of these. This one I thought was interesting. Vera asked, I've heard Botox can help with bladder issues. Can you explain in what ways Botox can help?
All right, so if you've got a hyperactive bladder that's constantly squeezing, Botox is a paralytic. So they will inject Botox into multiple points inside the bladder, and that paralyzes the bladder muscle, so it's not constantly squeezing and making you leak. And that usually lasts about 3 or 4 months.
I had no idea. That's really interesting. Somebody would like to know if you are over 65, are there any DMTs that generally work better?
Oh, we try if a person is stable over the age of 65, we try to get them to a lower efficacy medication that may not have the potential for long-term side effects. And that would be usually something like teriflunomide or Aubagio. Now, Aubagio is not covered under Medicare Part D because the drug companies can't help us with them, and it has a relatively high copay. Something like Mark Cuban's Cost Plus, you can get your Aubagio for about $14 a month. So you don't need your insurance to get it. But you're going to be paying a few $100s a month to get Aubagio per se. The other thing that you might want to try, and we're seeing more and more use of Mavenclad as an exit strategy for older adults. Mavenclad is 5 days worth of pills 1 month. The next month you take 5 days worth of pills, and then you take a break for a year, and they repeat that in year 2. Those pills, you may be able to get help if you're on Medicare from the drug company. I know that I started Mavenclad because I'd been on Rituxan for nearly 11 years. I started Mavenclad last year, and EMD Serono, who's one of the sponsors of this webinar, makes that product, and they do have a program that helps people with Medicare who are under a certain income level to get free drug for that. So if you've got commercial insurance, you should be able to get it with no problem at all. But so we're looking at teriflunomide, we're looking at Mavenclad, both of those are oral. The other thing that if you're open to it, you might try would be one of the earlier platform drugs like Copaxone or Betaseron or similar drugs.
Okay. That's amazing. I mean, just the amount of money that it takes to somebody pay out of pocket, and then for something like Parcuban's company to come and be such a savior for many is just an incredible story. So somebody would like to know, how do I know when I have a relapse?
Relapse is considered as a new or resuming symptom, worsening symptom that is present for longer than 24 hours and is not relieved by rest, and it's also or cooling, and it's also in the absence of a fever or infection. I find that I used to get urinary tract infections often, and my MS symptoms would always get worse, and I would think that I was having a relapse because I was not having typical symptoms of a urinary tract infection or UTI. Um, and so we've gotten to the point now where um, my husband will pick up on the fact that I may have a UTI just from the way I'm responding. Um, and so if that's treated, and the symptoms get better, it's not a relapse. So in the absence of an infection of any kind, or you could be coming down with a flu, give it a couple of days, and if the symptoms continue to progress, then you need to contact your neurologist. Please don't go to the emergency room for relapses because they're really not equipped to treat you. Wait it out and contact your neurologist on Monday morning. Monday morning if it's on the weekend. Okay?
Okay, Cherie, we're going to have one more question, then we're going to wrap it up.
Okay.
This is from Christina. She asked, is the 3 months before and after an infusion mandatory for receiving vaccines, i.e. flu, shot, shingles,
No.
etc.?
We used to think that with Tysabri, obviously that's a monthly infusion, but with any of the B cell infusions that are 6 months apart, when we were dealing with COVID, we would think that you would have your greatest chance of immunity just before your infusion. So sometimes we even stretched the infusions out to give people a better chance. We now know that if you've been on that drug for longer than a year, that you're not going to be dipping back down with your B cells. And so you may have a blunted immune response to any vaccine if you're on this class of drug, uh, but it can be given at any point during that infusion cycle. I would probably avoid getting it within the first 3 months after your infusion because you're going to have your peak suppression at that point. So you can technically get it at any point.
Okay. This has been extremely enlightening and informative, Cherie. I am so grateful for your time and your expertise, and I'm sure everyone else is as well. We're getting some amazing comments. Thank you, Cherie. You always rock. Cherie, if for those individuals who may have not been able to get their question answered, what other formats or ways can they possibly get their questions answered by you? Do you have like another webinar that you usually do?
I will be doing a webinar next month. I'm not
Hmm.
sure. I think next month is the Ask the MS Nurse.
Yeah.
But anytime you ever have a question, you can always email me at Cherie@msfocus.org. That's my Bhavya just ticked that into the chat. So and I do try to get an answer back to you within the day. So Cherie@msfocus.org. That's Cherie. Thank you.
I'm sure everyone appreciates you being so open to answering their questions. So for everyone else, that brings us to the end of this event. If you missed any part, it has been recorded and will be available through MS Focus Facebook and YouTube channels. If you go to our Facebook feed immediately after this completes, it will be up in its entirety. Please reply to your registration email for more information. By participating in a short survey sent to you after this webinar, you'll help us learn what information is most meaningful and helpful to us as attendees of these conferences. Join us next Tuesday, March 11th at 4:30 p.m. Eastern with Dr. Ben Thrower to discuss what's in the pipeline and finding the right MS medication. Thank you to everyone for joining us today, especially to Cherie for educating us on this important topic. Once again, we'd like to thank our wonderful sponsors, Genentech, Novartis, EMD Serono, and Sanofi. Have a great rest of your day, everyone. Thank you so much.